Hi, I'm Dr. Jeff Buxton. I'm here with Dr. Billy Arnold. We're going to talk about adenoids and tonsils today and how the inflammation of your adenoids and tonsils could be related to mouth breathing. Let's get started. What do you think, Billy?
It's a very complex issue, so we'll try to dive into a lot of it today.
Maybe we should start with what is it that causes the inflammation of the tonsils and adenoids? What's kind of the healthiest way for us to breathe so we don't get this inflammation?
Yeah, I think that's why nasal breathing is so important, right? We were born obligate nasal breathers. The nose is there for a reason. The nose is for breathing and smelling. The mouth's for eating, talking, and drinking. So if we focus on nasal breathing, the nose is going to do a lot of things, including filtering out those particles, whether they be viruses, bacteria, fungi, environmental irritants, like you said. And depending on the literature you read, I think it's anywhere from 98 to 99% of filtration is done by the nose. And if we're breathing through our mouth, then all of that immune function is kind of put on those tonsils and adenoids. You're not getting the warming of the air. You're not getting the filtering of the air. I think when we're breathing through the nose, we're getting most of that stuff filtered out, and then the tonsils and adenoids are doing kind of their normal work versus if we're breathing through the mouth, then they got to do 100% of the work.
So the nose is basically the first line of defense. And if we're mouth breathing, we're skipping that first line of defense. And so our tonsils and adenoids are having to be stressed harder because they're having to deal with those irritants and allergens and such. Is that kind of what you're saying?
Yeah, I think they got to do the brunt of the work when you're mouth breathing versus they're doing their standard work when you're nasal breathing.
Yeah. And so then when those tonsils are inflamed or the adenoids are inflamed, how does that affect breathing during the daytime and at nighttime?
Well, I think if they're enlarged and kind of blocking the airway, then I think instinctually people will open their mouth because they feel like they get better airflow, less nasal airflow resistance. And then you can kind of create just a bad habit of mouth breathing versus getting our tongue in the right posture, tongue up, lips closed, healthy breathing through the nose. Hopefully it's silent nasal breathing.
Yeah.
But I think that definitely can impact. And that goes back to your first question. Is it, the chicken or the egg? Which one's first? And I think it could go both ways, which makes it hard to then get to the root cause.
For sure.
Nasal breathing is healthy breathing. If we're mouth breathing, I think so many things in our body are going to be affected.
Yeah. So for like a parent who doesn't know, like during the daytime, you can tell if someone's mouth breathing. Their mouth is usually open. You can see them visually breathing through their mouth. At nighttime, when a child is asleep, how are you able to tell if they're mouth breathing? What are some of the signs you would look for? What are some of those things that a parent could clue in and say, okay, yeah, I heard Dr. Arnold speak on this podcast, and he said to look for this, and this is what I'm seeing in my kid?
I think the first thing is just awareness. I think there's a lot of families that I see that aren't even aware that nasal breathing and mouth breathing is any different. So one, just being aware that, hey, we want our kids nasal breathing as close to 100% of the time as possible. So one, being aware. So then you can start noticing throughout the day, okay, maybe when my kid is reading a book or screen time, when they're like really locked in on something and they're not paying attention, I think that's when we start to see that mouth posture kind of open up. So I think that's for the daytime. Nighttime's hard, right? You're not, depending on what age the kid is, then the parents, we're in separate rooms. So I'll encourage parents to just kind of check in. Typically the kids are going to go to bed first, and then the parents can kind of check in throughout the night. There's also a variety of apps now that you can put next to your bed, and that will record the sleep. So then maybe we can catch some of those sleep disturbances, whether it be noisy mouth breathing, whether it be snoring. Grinding is one that I'm always looking for. So kind of the big three to me that I'm talking with parents is snoring, grinding, mouth breathing. I think those three are early red flags. Mouth breathing is probably the earliest one. And so if we start seeing a little bit of that, then it's like, let's dive deeper. But I think dysfunctional breathing during the day is typically worse during the night.
Okay. Yeah. That is what I see kind of as well. When you get children that are mouth breathers and they begin to breathe through their nose, Would you expect to see the tonsils and the adenoids begin to reduce and the inflammation to reduce?
I mean, I have a lot of patients who have been in that gray area where they're seeing an ENT, they're debating tonsils and adenoid surgery. They don't want to do the tonsils and adenoid surgery. And so we offer them different options. And part of that is going to be a growth modification, whether that be with a device like Toothpillow or palatal expanders, also doing some myofunctional therapy, nasal hygiene, kind of doing those steps. So we see kids where we'll do a combination of those three. They'll return to their ENT 6 months later. And then the ENT at that point says, there's nothing to take out. So I've seen it with some of our patients. Does it always happen? No. I think sometimes it's so severe that, maybe tonsils and adenoid surgery is needed. But then on the other side, we also see kids who will get the TNA. Parents report immediate improvements. And then 3 months later, 4 months, 5 months, they start slipping and they start to kind of regress and relapse. So I see that a lot. And I'll stress to those parents, like, look, tonsils and adenoids is one component, but we need to address the underlying cause. So we need to get your kid nasal breathing as much as possible. We need to get some growth modification. What are you looking for in adults versus kids, since you're treating both?
So mouth breathing in adults, what I'm looking for is chapped lips. Do they wake up with chapped lips? Do they wake up and they have to go get a drink of water in the night? That would indicate to me that they're mouth breathing. And then, of course, grinding and clenching. Patients with the severe tooth wear, that indicates to me that they're grinding their teeth at night, which is kind of weird. I'm talking about mouth breathing with the mouth open. Why would their teeth be together and their lips possibly be together and they're grinding their teeth? And so their mouth is open, but as they're laying down and their mouth is open, their tongue is falling back. And so the body then responds to that by closing the teeth together and pushing the lower jaw forward, and then the grinding happens. So they grind in an effort to get more oxygen into their system. And once they get that oxygen into their system, then they'll usually go back to the mouth breathing again, and the mouth will come open, and then they'll wake from that and they'll start to grind, get more oxygen, and the cycle just repeats itself all night long.
I'm sure that helps with your restorative work too, right?
Absolutely. You get a patient who comes in and they get, these beautiful veneers on, and they start grinding at night, and they're going to break the veneers, or they're going to break their crowns, or just their teeth in general, and it's going to wear things down. So if we can get adults as well breathing through their nose when they're sleeping at night, it's going to protect their teeth, but it's also going to improve their sleep. It's going to improve their breathing. So, but if we can get it treated in kids, we can avoid this in adults, right? So that's the great thing about Toothpillow is we're really working and focusing on getting kids into where they need to be so that they don't become adults with disease. Obstructive sleep apnea, snoring, mouth breathing, all of those things. If we were to maybe classify the severity of mouth breathing, sleep apnea, snoring, like, is there one that kind of is there some type of system where we should be looking for this first before it becomes full-blown sleep apnea? What could, for the viewers, like, what could they be looking at so that they know, hey, this is something I should jump on and fix before it becomes the doctor prescribing me a CPAP mask that I have to wear all night and sleep in?
Yeah, I mean, it's a sliding scale, right? The healthiest form is going to be nasal breathing pretty much 100% of the time. The unhealthiest form is going to be, obstructive sleep apnea. So I view sleep apnea as kind of grade 4, and then the snoring, grinding, mouth breathing, noisy breathing, that's more like stage 1. So no one's going to wait till stage 4 to treat if we're thinking of other things. So that's my view, is like, why wait till stage 4? Why wait till we have all those comorbidities that we know are involved with sleep apnea? Why not get in there earlier when they're mouth breathing, or a little bit of snoring or some grinding? Like, those are the first red flags, or kind of like the smoke before the fire. For sure. Everyone that has a CPAP today and has sleep apnea, they started somewhere, and it was probably mouth breathing, maybe some snoring, or a little bit of grinding. And who knows at what age. And if they've been doing that their whole life, the sooner we can get them breathing better, sleeping better, and being better, just much better for their systemic health. So, my father has sleep apnea, and, once you get sleep apnea, then you're at greater risk for a lot of things. So your cardiac arrhythmias, like atrial fibrillation, once you have that, cerebrovascular events dramatically rise, cardiovascular events dramatically rise. So I don't want to mess with that. Like if I see a kid snoring, even if it's a little bit of mouth breathing, I don't even want to think about them ending up with sleep apnea and then having to deal with cardiovascular issues. So that's why I like the early intervention. So, like the Toothpillow program, it's all about getting in there early, growing the face, getting that facial growth, getting that airway and jaw growth early on to try to minimize and prevent the more severe stuff later.
So patients who have obstructive sleep apnea they're pretty much in a sympathetic state, right? A sympathetic state is what we know as fight or flight. And when we sleep at night, we want to get into a parasympathetic state, which is the rest and digest. And that's when the body is healing and recovering from things. And so these comorbidities that you're mentioning, like cardiovascular issues, if we're not getting proper sleep, what you're saying is our heart is working harder, right? And if our heart is working harder, it could possibly raise blood pressure. It could lead to cardiovascular events. And in some cases, sudden cardiac arrest, right? Like my grandfather, he passed away in his sleep. And at the time, this was 1979, obstructive sleep apnea was not on the radar at that time, but he died in his sleep. And what I know now is more than likely he had obstructive sleep apnea and he had a sudden cardiac arrest, which led to his death. But if he would have been treated for an obstructive sleep apnea at the time, maybe he wouldn't have had that cardiovascular incident. So that's kind of what you're saying?
That's kind of why I became passionate about it, is like I see that downstream and it's scary and it's sad, and I don't want to think about that. So, for me as a pediatric specialist, my focus is like I want these kids as healthy as possible, like breathing well, sleeping well, and then that way they can live a long, great, fulfilling life, a healthy life.
For sure.
Too, versus a lifetime of unhealthy breathing patterns, which are just going to make the rest of your body less healthy.
We were talking in the other room before we came in here, the quote by Desmond Tutu, which is such a great quote. And it says, at some point we need to stop pulling bodies out of the river and we need to go upstream and find out why they're falling in. And so we have so many people that are struggling with heart disease. Heart disease is the number one killer, right? Mm-hmm. And what we now know is breathing issues are going to affect your cardiovascular health. It's going to affect diabetes, dementia, Alzheimer's, numerous comorbidities that are associated with poor sleep. So what we're trying to do here is kind of take care of the kids before they even get to the river, right? There's even a chance for them to fall in. So what are some of the things that we've established that mouth breathing is not healthy and that we need to establish nasal breathing and that we're designed to nasal breathe. What are some of the options that you feel are most effective in your clinical experience for reversing that mouth breathing into a habit of nasal breathing?
Yeah. So then I think it depends on the age, right? So I ideally don't want to reverse anything. I just want to promote the correct patterns of breathing early on. And so for me, I've just going back to the Desmond Tutu quote, further and further upstream, right? So for me, then I got to babies and infants and how to promote oral motor therapy and oral motor function, which is going to be related to nursing. So helping moms nurse for however long they and the baby want to. But I think nursing is one of the earliest forms of orthodontic or facial growth and development. The way they have to use their tongue and their facial muscles encourages better facial growth. If they're nursing, they're also nasal breathing. So those are like some of the earlier things, but you could go further upstream with that with before pregnancy and then during pregnancy of diet and how's mom breathing. And as moms get into that third trimester, typically sleeping becomes more difficult and the breathing is more difficult because they got a lot more on board, I guess. So again, going as far upstream. So early on for infants, it's going to be how do we help moms nurse, then develop oral motor skills. So there's different things that you can use. Like one of them is called the Myo Munchie. There's different T-tube teethers. There's all sorts of little tools that the oral motor therapists that I work with are using to promote better tongue and facial muscle use and development, which then includes nasal breathing indirectly. I don't even think that's their goal, but by improving that oral motor tone and oral motor function, I think we get better nasal breathing. So I think that's really early on, probably 2 and under. Then you get to an age where you can't rely on infant reflexes, but you can't rely on cooperation. So I think there's like a play-based phase, anywhere from 2 to 4, where we can try to promote myofunctional therapy stuff, nasal hygiene, teaching our kids how to blow their nose sooner, incorporating nasal saline sprays, and then using play-based or food-based therapy type options. So I have a lot of really great myofunctional therapists and feeding therapists and speech language pathologists that I get to work with in California. And so I've learned a lot from them about how they're trying to improve these kids from a functional standpoint. And I view everything that they're doing as kind of like this growth modification. Like they are doing early orthodontics. So I think if we can get everyone, I wish our system, our healthcare system would promote this more of the prevention and function focused model. But if we could get all these kids into these oral motor therapy programs, using the right tools, skipping sippy cups, not using pouches and purees, or being mindful of how we use pouches and purees. There's a time and place for everything. But getting them chewing more real foods. We were talking about the farm and, kids growing up on a farm and they're eating different types of foods. And so that promotes better growth and development. But I think myofunctional therapy early, and then, ideally trying to incorporate some sort of appliance, because you could do everything right and your kid's jaw's probably still not going to grow to where it needs to be to fit all 32 teeth. So we got to use other tools. So Toothpillow is a tool. There's a bunch of different guides that we can use, but this program is an all-inclusive program to focus on the foundation of health, get kids nasal breathing, and start growing the face earlier. So that's kind of the young side. And then as you get older, then it's more fixed palatal expanders, expansion for both upper and lower jaws. And, some people don't want to talk about expansion of lower jaws. It's more uprighting. It's more arch development. I know we're not expanding the suture, but we can get arch development, we can get uprighting, and we can improve tongue space. And that the more space the tongue has, then it's not going to be sitting back in the airway.
I love that. One of the ways I look at that is the tongue is pressing up against the roof of the mouth, right? And it's helping to guide the growth of the bones. And I look at it this way is as the bones grow, it's almost like making a bigger car so you can fit all 32 people in the car, or in this case, 32 teeth in the car, right? Because if it's not big enough, that's why teeth come in and you have crowding, and then you need orthodontics to straighten the teeth. But if we can build a bigger structure for the teeth, then the tongue is going to be able to fit properly, and it's going to be forward. It's going to lead to better breathing. What would you say to parents who would ask, can we avoid braces by doing myofunctional therapy and the guides? I mean, what's your experience there?
I think there are cases where we can, right? If we're doing myofunctional therapy, if we're using guides, consistency is huge, right? If we're not using them, I think the guides for the right families that are consistent with it. I mean, we have colleagues who've done this for 20, 30 years, and they have a lot of patients who have only used guides, never metal in the mouth, never a palatal expander, never braces, and they have all 32 teeth. So it can be done. It definitely can be done. Again, I don't know if it's going to work for everybody, right? There's always some sort of genetic component, but really what we're learning is the epigenetic component is the bigger component, and that's the one that we can play with and encourage growth in the right direction.
For viewers who aren't familiar with that term epigenetics, what does that mean? How would you define that?
I mean, I guess epigenetics is the environmental input to our genes, which will either kind of upregulate or downregulate genes. And so I think nasal breathing epigenetically promotes better facial growth. I think chewing on hard foods epigenetically promotes better facial growth, where you're turning those genes up, versus if we're just eating pouches, if we're just doing purees, we're not getting that epigenetic influence to turn those genes up, and we're kind of turning them down. And so then you get smaller and smaller mouths. I was reading an article the other day. It was talking about aglossia. So sometimes people are born without a tongue. And we hear from families all the time, oh, well, it's genetics, right? My father, my mom, my grandfather, they all had small mouths and they needed teeth extracted. But it's hard for me to say, well, it's more epigenetics. But I think when I saw that article about aglossia and not having a tongue, and you see how these jaws develop and they are tiny and there's just no space for anything. So if it was genetics, the jaw would be fine. But because they don't have a tongue, they don't have the driving force of facial growth, then the jaws don't grow and they don't develop. So I thought that was kind of an interesting article. But,
Yeah.
I think we're all so ingrained to think everything is genetics. So again, this goes back to education and just awareness that the little things that we do early on can really affect positively or negatively kind of our kids' facial growth and airway growth and development.
I mean, that would make a lot of sense when we look at the health of our population today, right? We're not genetically more unhealthy or genetically obese, right? Our diet and the environment, the air we breathe, these are all factors that are having some sort of impact on our genetic code, right?
These are all things that we can work together and educate families and really everyone that, hey, there are things we can do, little easy things that we can do to promote better health from earlier on versus waiting till things get bad.
Yeah.
And you said something earlier, it made me think of like the common versus normal, right? Like common does not equal normal.
Yeah.
And I think a lot of us conflate that, and I think we've mixed that up.
Absolutely.
Where, small jaws are very common, but it's not normal. Crowded teeth is very common, but it isn't really normal, right? A normal developing human jaw should fit 32 teeth, plain and simple, I think.
Yeah.
And we just don't see that now.
We see that kind of throughout all of medicine. I think about blood tests. I go and get my blood drawn and I look at my levels and it says I'm in this, wide range of normal. And I always ask myself, well, what is normal? And normal is the average or what's common for that age group. And I don't want to be normal. I don't want to be what's common. I want to be what's optimal. And so we don't see that on the blood tests. Like what are the optimal levels for your hormones or for, all of the things that we can find in our blood, right?
Any markers that we're testing.
Exactly.
And this goes to a conversation that I have with parents. It's like, do you want your kid to thrive? I mean, do we want to optimize their health? Then these are steps that we can take. If we want to be normal, and unfortunately the standard American diet and the normal American society is a very sick society. It's a very medicated society. Yeah. And I think if we want to do that, that's fine. I'm not interested in that. I want healthy people. I want to optimize their health. And I think that starts early on. But we also have to change a mindset. And I think that's the hard part. And there's also system things that we got to battle with insurance and pharma and food. I think all those three things play a big role in this, and there's a lot of money in that. Yeah. So I think that makes it tough. It's tough for a solo practitioner. We were talking about research, right? It's tough for us to do a RCT trial in our clinic.
Yeah.
Versus most of those are paid for by big companies, so it's hard.
It is. It's hard, which is what I'm so thrilled to see about this movement that we're experiencing right now. We're seeing a large amount of dentists and ENTs and myofunctional therapists that are working together and that are trying to help children become healthier. And we have a lot of parents out there that are searching for what is best for my child. The system has failed us, and we need something to help our child thrive. What we see is with children who aren't sleeping very well, we see, I think some of the studies are showing about a 10 IQ point drop for kids who are not getting sufficient sleep. And we haven't even touched on that of how insufficient or poor quality or fragmented sleep, whatever you want to call it, how that affects behavioral outcomes in school and academic pursuits as well.
There's a lot of things that we were taught in dental school that were normal, which we know are not. So going back to the grinding, like I said, grinding is normal until age 7, until once the first molars come in, and then they typically grow out of it until I learned more. And then now anytime I see grinding or, flat teeth, I'm airway. I'm thinking airway. I'm thinking sleep quality. Like, how are we breathing? How are we sleeping?
Yeah. I wanted to get back a little bit, if we can go back a little bit to adenoids and tonsils and how that's related to ear infections and throat infections. And then also a little bit of like, why is the tongue so important in this, right? What about tongue dysfunction, and what is myofunctional therapy, and what is that, how does that help? So, my understanding is that as the tonsils become inflamed, they can block off the eustachian tube as it drains into our throat. So we get, bacteria, we get fluid into our ear canals, and that empties into our throat. We swallow it down into our digestive system. And so if the eustachian tubes are not able to drain, it's going to lead to ear infections. And we're seeing that in a lot of kids who have mouth breathing and tonsils and adenoids. That's another thing that you should look at for your kid, right?
Remember, the eustachian tube is very flat for kids. And then as we age, then it becomes more vertical, right? So that's why kids tend to get ear infections and adults don't really get it, because just the gravity of the tube will kind of drain it naturally. So like you were saying, tonsils and adenoids, when it gets so inflamed, it can kind of push on that and prevent some of the drainage. But also if you're not using the tongue correctly, there's a little muscle connected to the back of the tongue that pulls on the eustachian tube, and that helps it drain. So a proper swallow pattern really helps prevent the ear infections. Again, the ear infection is a symptom of an underlying muscular dysfunction. And so I think if we get these kids swallowing properly, those tubes are going to drain, and then we're going to get less ear infections. Is it going to prevent it entirely? Probably not, but if again, getting to the root cause of it. So that's what I see. So I'll have a lot of families come in, ear infection. They'll give them antibiotics. Typically, at least in California right now, it's like once you've had 7 antibiotics in a year, then you're having tubes. We're not even thinking about what the antibiotics are doing to the kids, both short term and long term. I don't know how much hypoplasia you're seeing, but to me, it seems like a lot of 6-year molars are very hypoplastic, which those 6-year molars are forming when most of these kids are getting those ear infections, and then 7 rounds of antibiotics. Yeah.
You see that tooth come in and it's brown and soft, and in some cases there's already decay.
Yeah. And then, I don't know how you treat them. I'll try to seal them, or sometimes I'll put a band on them. Some severe cases, I'll even put a stainless steel crown on it, because they're just mush. They'll just like break apart. The ear, I think that's an early sign when I see that on a health history form, a lot of infections. I'm looking for oral motor function, possibly a tongue tie. But I'm promoting that myofunctional therapy. So, you touched on myofunctional therapy. The goals: healthy nasal breathing, tongue is up, resting on the roof of the mouth, so a good tongue posture. Lips are closed, so we get lip competence, and then a healthy swallow pattern, or correct swallow pattern. So that's the goal of myofunctional therapy. Is, again, it's just optimizing our facial muscle use.
So for those who don't know what myofunctional therapy, it's basically physical therapy for the tongue. Correct?
Yeah, in the mouth. I think all the muscles of the upper airway.
Correct.
The tongue being, the main one.
Yeah.
And again, the tongue is an organ, right? The tongue is a bunch of different muscles going different directions, connected to different things. Yeah. So it's not just one muscle.
Yeah, and we haven't even touched on that, and the tongue and the fascial system and how that's related. And we've talked about in the other room about shoulder tightness and neck tightness, also related to tongue tightness as well. A lot of parents would probably think, well, how do I go get my child assessed for proper swallow, for tongue tie, for nasal breathing? A properly trained airway-focused dentist would be able to look at all these things and provide a good diagnosis and get the patient into the hands of the right provider.
hopefully.
Yeah.
You know, the ADA, I think in 2017 said that it's mandatory that we all, as dentists, all need to be looking for airway and doing airway screening. The adoption is a little bit slower than the mandate, but I think more and more people are being educated on it. So trying to find an airway focused provider near you, but not everyone has that, right? I mean, I'm in two areas. I go between Orange County and the Bay Area in California. So two pretty affluent areas with a high density of providers. So I don't really have that problem, but then there's more rural areas where maybe there's only one dentist in town and they haven't been educated on the airway yet. And so they don't really know. And so I think, you know, like Toothpillow program would be great for those people where like, hey, maybe you don't have a provider near you that's educated in this. So let's get you screened and then we will hook you up with the right people, whether that be a myofunctional therapist or a motor therapist, speech language pathologist, a dentist, an orthodontist, a pediatric dentist. So at least that way we can still be screening these kids early on and start getting that early intervention versus if they didn't have that virtual option, then you're kind of just stuck with, you know, whatever's nearby. Yeah. So I think that's an awesome thing that, you know, now with technology and the internet and social media and everything is the awareness is there. And then, you know, we as providers, we just need to keep pushing and getting our colleagues aware of it. And, you know, I think the more we work together and take that collaborative approach, more and more people are going to get on board here.
So all of these things we've established are so important for the health of kids. Parents are going to want to get in touch with a provider who's going to be able to provide their child with the best care possible. Should a parent go about that, finding a dentist or a provider who is going to set their child up with the appropriate treatments to get them on a good foundation and head start for optimal health?
Yeah, at first I think every child should be assessed for airway. The ADA has said it, the AAPD is now saying it. So first, every child I think needs to be assessed for airway. Then it's how do we find a provider? So that's why I love the Toothpillow program. You know, both you and I are virtual providers, so our specialty is airway. So any parent who has a kid that's concerned or maybe just learning about this now, whether they have a bunch of symptoms or not, can go online and get their kid assessed virtually for free. So at least they can get some information. Yeah, at least they can get some information. And whether the Toothpillow program works with them, they can be treated with the Toothpillow program, or sometimes the Toothpillow program will hook them up with an airway-focused provider in their area. So they collaborate with airway dentists and myofunctional therapists in whatever area you're in. I think we have providers in every state, and it seems to be growing every day. Yeah, so everyone needs to be assessed, and the Toothpillow program really allows an easy way and a free way for parents to get their kids assessed so they can get the information and start making the decisions that they need to for their child's health.
Yeah, that's awesome. And it's incredible that this has been established to provide that. We really are trying to fill a void and to comply with the mandate from the American Dental Association to be screening children. A lot of questions I get from parents are, well, what is Toothpillow? What does the appliance look like? And this here is the appliance. The appliance is worn in the nighttime and during daytime. And it has, I don't know if the camera can see this, but there's a little tab on the top there that what it does is it trains the tongue to go to the roof of the mouth, because child's tongue is going to be playing with this tab and pushing up against it all night long. The other important thing it does is it creates a lip seal, so mouth breathing cannot happen, right? Which then helps to direct nasal breathing.
A simple appliance with profound impacts.
Profound impacts.
Yeah. So very cool.
And the neat thing is it can be done virtually, right? Time is our greatest, asset or commodity. And if this can be done virtually, it's a huge benefit to parents. One thing that we see is parents are so busy with their kids in school and with extracurricular activities to find the time to go in to a local dentist and be followed up on this is a little difficult. But to be able to do it virtually is such a benefit to them.
on their own time. The
On their own
weekend, the
time.
night, once the kid's asleep, they can submit this. They could talk with us.
Yeah.
You know, we talk with them. So yeah, I think it provides a great option for so many families around the country.
Yeah.
So I'm proud to be a part of it.
Absolutely. Absolutely. Well,
It was nice chatting with you.
Yeah, great chatting with you.
Good seeing you.
And yeah, if you have any questions or want to do more research, toothpillow.com is an incredible resource. Of course, we've got an Instagram channel and a YouTube channel. So we are here to answer your questions and to serve our communities. So thank you.